People joining us from
Yes, sir.
outside. Yes,
Three, two,
good.
one, start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Man Singh Medical College, Jaipur. Today, we are going to talk on an interesting topic. This is related to female sexual dysfunction. And this will be presented by our resident, Dr. Rajeev Sharma, and will be moderated by our faculty, Dr. Dharmendra Jangid. So I would request Dr. Rajeev Sharma to kindly share his presentation.
Good morning, respected teachers and my dear colleagues. Today's topic for seminar is female sexual dysfunction. According to International Societies for the Study of Women's Sexual Health, and it defines female sexual dysfunction as a disorder that causes significant personal distress and negatively impacts the quality of life. Symptoms can be lack of motivation for sexual activity, pain associated with intercourse, vaginal dryness, vaginismus, and delayed orgasm. The symptoms should last for at least 6 months and they should be accompanied by significant personal distress. The various types are they can be female sexual interest or arousal disorder, female sexual orgasmic disorders, genitopelvic pain, substance or medication induced sexual dysfunction. The epidemiology of female sexual dysfunction, the hypoactive sexual arousal desire is the most prevalent sexual complaint existing for around 21.4% of the patients. It is closely followed by arousal and satisfaction disorder. This periunia is relatively uncommon in premenopausal women than among those with postmenopausal women. According to Placid model of assessment, the patient is first granted the permission to talk about her sexual disorder. Then the patient is provided with the limited information which provides the basic accurate sex education. Then patient is given the specific suggestion that provides simple suggestion to increase the sexual function, like use of lubricants and vibrator. In the intensive therapy, the patient is given referred to the subspecialist. In the biopsychosocial model for assessing sexual dysfunction, the various biological factors which can affect the sexual disorder are like medication, hormonal status, neurobiology, physical health, and aging. In psychological factors, the patient has depression and anxiety, substance abuse. Socio-cultural factors can be related to upbringing of the patient and cultural norms. The interpersonal relationship with the patient and the partner or the life stresses. Female sexual function index score, it ranges from 2 to 36, with 36 representing the perfect score, indicating better sexual functioning. A score of less than 26.55 is considered as a risk for sexual dysfunction. The various medical conditions that can affect the female sexual function are coronary artery disease, diabetes mellitus, malignancies of the breast or the colorectal cancer, neuromuscular disorders like those of spinal cord injury and Parkinson's disease. Physical examination in this pelvic examination is especially important for women with dyspareunia and vaginismus. Examination includes vaginal atrophy, looking for vaginal dryness or any genital tract infection, pelvic floor muscle dysfunction, and adnexal masses. Considering the association between LUTs and sexual health issues, a simple Q-tip test is warranted for looking for urinary incontinence. These images show the impact of vulvar lichen sclerosis and atrophic villi on the female sexual function. Cotton swab test is used for vulvodynia. In this, the pain is provoked in the vestibule or interlabile sulci or introitus by light touch from a moistened cotton swab. Laboratory tests indicated if there is a suspicion for specific medical condition. The free testosterone levels less than the lowest quartile may be associated with androgen insufficiency syndrome. The routine measurement of estrogen levels is not useful. Genital blood flow can be measured with vaginal photoplethysmography, which is the most widely studied and most validated physiological test for assessment of female sexual function. Next comes to female sexual interest disorder. It is defined as absence or marked reduction in the desire to engage in sexual activity, which is manifested by reduced spontaneous desire, reduced responsiveness to sexual or erotic stimulation, and inability to sustain desire or interest during sexual activity. The pathophysiology behind the sexual desire, it is as a result of delicate balance between neuromodulators of excitatory pathway and inhibitory pathway, where the chief hormone for excitatory pathway is dopamine and norepinephrine, and those involved in the inhibitory pathway are serotonin and prolactin. Conditions that are associated with low sexual desire. These can be hypertension, diabetes mellitus metabolic syndrome, renal failure, spinal cord injury, or neuromuscular disorders, Parkinson's disease. Various classes of medications which are associated with low sexual desire. These are medications given in cardiovascular disorders like diuretics, digoxin, hormones like anti-androgens, psychotropic medications, illicit drugs like amphetamines, cocaine, and marijuana. This table shows treatment algorithm for hyperactive sexual desire disorder. In this, the patient is routinely screened for HSDD by direct questioning or by sexual desire screener. If the findings are suggestive of HSDD, then further evaluation is done by thorough sexual history, medical history, psychosocial history, and focused physical examination. And if the patient is found to have HSDD which is generalized or acquired and not related to any medication or drug abuse, then patient is given FDA approved flibanserin or any of the off-label transdermal testosterone patches. And then further patient is evaluated for the responsiveness to the drugs. In case the HSDD is due to any unresolved issues related to sexual trauma, then patient is referred to the subspecialist. Treatment. It involves psychosocial and biological approaches, which is recommended in a sequence that gives priority to the most distressing aspects of the problem. Initially, modifiable factors that are thought to be playing a role in HSDD should be addressed. Cognitive behavioral therapy and mindfulness therapy are the most commonly employed psychological interventions in HSDD. Medical treatment involves use of hormones. In patients with menopause, there is decrease in level of estrogen. So replacing estrogen with exogenous source is the most straightforward approach to ameliorate hypoestrogenism. Ospemifene is a selective estrogen receptor modulator with indication for treatment of vulvovaginal atrophy and dyspareunia. Substantial evidence suggests that testosterone therapy positively influences overall sexual wellness in postmenopausal women with low desire. Tibolone was found to be superior to hormone replacement therapy in improving general sexual satisfaction. Then bupropion, which has also been shown to be effective in reversing SSRI-induced sexual dysfunction. Another drug is buspirone. Flibanserin, which is the only FDA-approved medication that can be used in management of premenopausal women with low sexual desire. It is given in a dose of 100 mg per day. It is a non-hormonal centrally acting drug, which is post-synaptic 5-HT1A receptor agonist. Next comes the female orgasmic disorder, which is the second most common sexual dysfunction among women. To arrive at the diagnosis of FOD, it is necessary to rule out the medical conditions or pharmacological interventions. A comprehensive sexual history is essential to diagnose and characterize FOD. The treatment involves education, which is the hallmark of any treatment addressing FOD, informing the patient and the partner about the female sexual anatomy, physiology, as well as responsiveness to orgasm, which can be climaxed by different stimulation techniques, constitute the first step of treatment. Directed masturbation and sensate focus. Directed masturbation is a behavioral technique involving self-awareness. It aims to familiarize the patient about her anatomy, her genital, and other erotic areas of her body. Sensate focus consists of graded exposure from non-sexual to sexual touching to acquaint sexual pleasures. Coital enlightenment technique, it focuses on maximizing the glans clitoris stimulation. It aims to increase the frequency of women achieving orgasm. In this coital position, the man positions his pelvis above the pubic bone of his partner. The woman stretches her legs and folds them around his. The penetration of the penis is less deep, but the glans clitoris stimulation is more strongly stimulated than with conventional intercourse. Sexual enhancement products like vibrators and sexually explicit media are helpful. A common concern about use of vibrator is that the woman will be dependent on this type of stimulation and will avoid sexual intercourse. Vibrator use has been associated with higher sexual scores in sexual function domains. The Eros device, which is a small battery-powered handheld vacuum device, is used directly over the clitoris and engorges the clitoris and labia with the blood. This is the image of Eros device. Medical treatment. Female orgasmic disorders which are associated with desire and arousal problems are given phosphodiesterase 5 inhibitors. Those with sufficient arousal, they are given oxytocin on demand. Female sexual arousal syndrome. It is a persistent or recurrent inability to attain or maintain arousal. It occurs due to lack of concordance, which leads to weak relation between the subjective sexual arousal and objective sexual response. Pharmacotherapy for female sexual arousal disorder. Hormonal therapy. Testosterone and selective tissue estrogen activity regulators. Tibolone. Non-hormonal agents like phosphodiesterase 5 inhibitors, bupropion, oxytocin, dopamine agonists. Female persistent genital arousal syndrome. It is a spontaneous, intrusive, and unwanted genital arousal like tingling and throbbing sensation in the absence of sexual interest or desire. The treatment is given in the form of duloxetine, pregabalin, and penicillin. Genitopelvic pain and penetration disorder. Vulvodynia is described as the burning pain occurring in absence of any visible findings. This can be like localized vulvodynia, generalized vulvodynia, provoked and unprovoked vulvodynia. In patients with provoked vestibulodynia, primary PVD is the pain experiences the first attempt of any type of vaginal penetration, may be tampons or sexual activity. Secondary PVD is the pain experienced after a certain period pertaining to vaginal penetrative activity that previously were pain-free. This condition is typically acquired and has a late onset. Pathogenesis. Vaginal secretion seems to play an important role. Human epididymis protein 4 and secretory leukocyte protease inhibitors are reduced in women with PVD. Primary PVD patients appear to have greater nerve fiber density and thicker vulvar vestibule. Clinical presentation. Menopause and dyspareunia. Between 10 to 40% of the postmenopausal women experience discomfort caused by vulvovaginal atrophy that requires treatment. Previous genitourinary surgery, such as POP surgery, is being closely scrutinized because of serious concerns regarding the life-changing complications. Treatment involves education, biofeedback, dilator, and insertion techniques. The use of vaginal dilators can help women with dyspareunia to control the fear of pain and promote pelvic floor relaxation during insertion. Electric stimulation is also helpful. Topical therapy with use of it's better than systemic therapy in reducing the density of vaginal, autonomic, and sensory nerve fibers. Surgery. Vestibulectomy is a surgical procedure that can be used for vestibulodynia. Lower urinary tract dysfunction and female sexual dysfunction. Most pelvic floor disorders are thought to negatively affect the female sexual health. Up to 45% of the women with urinary incontinence and LUTs complain of sexual dysfunction. Epidemiology. Sexual symptoms may occur in combination with other pelvic floor symptoms such as urinary incontinence and pelvic organ prolapse. These include coital urinary incontinence, orgasmic and penetration urinary incontinence, coital urinary urgency, where the patient feels urgency to void during vaginal intercourse, postcoital LUTs, which is worsened urinary frequency or urgency, receptive urethral intercourse, having a penis inserted, penetrated in one's urethra. Prolapse specific symptoms. These include abstinence as a result of pelvic organ prolapse, vaginal flatus, vaginal laxity or feeling of vaginal looseness, obstructed intercourse. Vaginal intercourse is difficult or not possible because of obstruction by genital prolapse or shortened vagina. Lower urinary tract symptoms and female sexual dysfunction. The lack of libido and reduced level of self-esteem because of a fear of uncontrolled leakage are the main factors in women with urinary incontinence. 70% patients have reported urine leak during penetration. The cure of coital incontinence is achieved 90% patient surgically. The female sexual function and dysfunctions are important aspects of urological practice. The urologist should be aware of the urological ramifications of sexual issues and vice versa. Appropriate treatment and referral of the woman with sexual concern does improve patient satisfaction and treatment compliance. Thank you.
So, thank you. So definitely the topic is a bit different and topic which has not been dealt with, not only in our department or in urology, but throughout the world. The research and the work that is done in male sexual dysfunction is not available in female sexual dysfunction. So, but surprisingly, female sexual dysfunction is more common than male sexual dysfunction. So I don't know whether you people know it or not. The study, the male Massachusetts study showed that around between 40 to 80 years, the male sexual dysfunction is around 32%, whereas there was a study in female sexual dysfunction which showed it's more than 43%, so 40 to 50%. So this is something which need to be dealt with. When we talk about defining female sexual dysfunction, WHO defines female sexual dysfunction as the inability of the women to participate in a sexual activity in the ways that we want, they wish to, and they are not able to. So, but we all know that female sexual dysfunction encompasses a lot of components, facets. It's not only just psychological and organic. It includes social, cultural, interpersonal relationship, the emotional behavior of the females, and many other things. The definition by the International Sexual Society is that it's a persistent or recurring decrease in sexual desire or arousal, difficulty or inability to achieve orgasm, difficulty or discomfort or pain during penetration, which all can lead to distress in the couple, right? So this is how female sexual dysfunction is defined. When we talk about evaluating a case of female sexual dysfunction, we must know how the female sexual response cycle works and how it is different from male sexual response cycle. We all know the sexual response cycle starts from kind of a fantasy, desire, excitement, arousal, orgasm, and a refractory period. So this is the curve which is there in sexual response cycle. The difference in male and female is that when there is arousal phase in male is kind of a steep phase, whereas in female it is a plateau phase where it takes some time to reach orgasm. The male can reach orgasm within maybe seconds or minutes, but the female takes time, right? So that the plateau phase is there during the arousal or excitement phase. Secondly, the refractory period. Once the male goes into a refractory period, they cannot have orgasm immediately after that. Whereas female can have orgasm even once they go into refractory period. So they can have multiple orgasms, right? So these are few things that need to be, and when we compare between male sexual and female sexual dysfunction, there are few interesting things to be noted. Besides this, the sexuality, the peak of sexuality in males usually is there in early adulthood, right? So the males have reached their peak almost at the early 20s, whereas the females reach their sexual peak almost in 40s or 50s, right? So they have a kind of a curve which slowly increases in 40s and then goes down after 50s. When we talk about evaluating, definitely they need to be evaluated as a couple because it's a couple's problem. And we need to take care of a lot of things, which is called a bio-socio-cultural kind of assessment while doing a female sexual evaluation, where you take care of the social aspects, the cultural aspects, the psychological aspects, the emotional aspects of the female before we can reach the diagnosis and the cause. So when we talk about the various problems associated with female sexual dysfunction, the most important is the decrease in sexual desire, which could be either hypoactive sexual desire disorder, or another thing is a sexual aversion disorder, where the female doesn't want at all to have sex, right? And then there could be an arousal disorder. Or then third is to difficulty in reaching orgasm. So orgasm could be the patient may not achieve orgasm. You must know that there are around 50 to 20% of women who have never experienced orgasm, right? So anorgasmia is an important problem. Secondly, there's a delayed orgasm, as in males, a delayed orgasm or delayed ejaculation. Similarly, in females, there's a delayed. Premature orgasm is usually unknown in females. And then you have the problems related to penetration. So the patient, the female may have difficulty or discomfort or pain while having the coital activity. So this could be related to kind of a vulvar disorder, vestibular disorders, pain due to endometriosis, the deep penetration pain, discomfort due to a lack of lubrication, dryness of the vagina, right? So all these are different causes for difficulty in pain, difficulty in penetration, and having problems. So these are the various kind of problems that you must think before you evaluate these cases. So history, again, very important. The history, you must take the family history, you must take the sexual history, the marital history, you must take even the there is psychogenic history, the interrelationship between the partner. All these things are very important while taking the history. And then on physical examination, the things which are important is the external genitalia, the vulva, the vagina, whether there is, because there are a lot of conditions like vulvodynia, vestibulodynia. There are glands there in the vulva and vestibule. There is Skene's gland. There is the Bartholin's gland. So all these glands can get inflamed. There could be neurological problem, which can result into vulvodynia. And then endometriosis can cause difficulty during dyspareunia. So all these are important while examining the patients. It is also important to know the erogenous zones, which a particular female can be more feeling more kind of excitement in this. So every female doesn't have the same erogenous zone or same excitement with those particular zones. So we have a G spot, which is called Grafenberg spot, which lies in the anterior vaginal wall near the mid-urethra. You have kind of a clitoral sensation. The most nerve endings are at the clitoris. So most women get more stimulated with clitoral stimulation. But again, there are two types of female who will reach orgasm with either clitoral stimulation or vaginal. That is called vaginal orgasm or clitoral. So all these are very important when we deal with patients who have dysorgasmia, female. Treatment part, again, he talked about the Plicit model. The implicit model is P stands for permission giving. So all this, when you talk in females about the sexual function, you must permit her. You must tell her that you just develop a rapport between and permit her to just come forward with her sexual problems. Then LI is limited information. You give some kind of information regarding the female sexual function, the female anatomy, regarding the dysfunction, etc. And then you give S is for specific suggestions, double S, specific suggestions. You give substance suggestions that, yes, these things can be problem. The desire could be less in women because of aging, because of less lubrication, because of this and that. And then continues the intensive therapy. So PLISSIT, PLISSIT. So this is a very important kind of a way to assess female sexual dysfunction. The treatment, we all know, we need the sex therapy, the sex counseling, sex positions, and all these are very important. Psychotherapy in these patients are important. We all know females are emotional creatures. So we have to think about that aspect of the females while taking care of the sexual function. And then we have to think about the organic causes. Again, the same cardiovascular factors also apply in females, hypertension, diabetes, etc. So they can have neurological causes, vasculogenic causes, because all these are important while having arousal and orgasm. So females also have increased blood flow during the arousal period and orgasm in the pelvic area. So the vagina gets ballooned up. There is a labia which gets increased. The clitoris increases in volume. There is increased blood supply in these areas. So all these are important. And then all these have a role in all kinds of female sexual function. And they are dependent upon neurological causes, the vascular causes, the hormonal causes, right? So again, these things are important while evaluating and trying to treat these patients. When we talk about then dryness has to be helped by, particularly post-menopausal women, with the help of hormones like estrogen, etc. And when there is a decreased sexual desire, we have hormones like testosterone analogs like tibolone, and then to increase the sexual desire, we have flubenserine. So there is some kind of a pharmacotherapy available to increase the vascular supply. We have the PDE5 inhibitors available. They also work in female sexual function dysfunction. So these are important. All are. Flubenserine, tibolone, all these are available in the market. We have then the PDE5 inhibitors definitely are available. They may not help as in other males because females, they are usually have a kind of a complex mechanism, and they can have a multi kind of a faceted etiology of the sexual dysfunction. So we have to take care of all these factors while treating these patients. So I think that was in nutshell about the female sexual dysfunctions. A lot more things to discuss, but anybody has any suggestion, anything, any idea, any query amongst our faculty, residents, and those who might have joined us today on Zoom. If you have anything to say, please raise your hand. We have Gurinder Kocher, we have VR Sate, we have many people who have joined us throughout the country, Nikhil Khattar. So anybody if has any question, otherwise we will go ahead with our MCQs, which we usually have.
So then these females, they usually won't come to us and say, I mean, first of all, why do they come to us and say, why don't the drugs manufacturers like flubenserine, why aren't we exposed to flubenserine? Because are they being treated by the gynecologist or by the second?
Yeah, first of all, the reason is, as I said, less work is done in female sexual dysfunction. So throughout the world, as it has been done in male sexual dysfunction. So there is less awareness amongst females, not only females and all, even our physicians and clinicians about the female sexual dysfunction. Secondly, yes, the females would be more comfortable going to their female doctors like gynecologists. And thirdly, this topic is still not very much dealt in our curriculum, in the various conferences that we do. And so definitely it requires more awareness, more kind of a discussion. Because as I said, female sexual dysfunction is more prevalent than male sexual dysfunction. So, yeah.
The female sexual dysfunction, it's always been a part of it's always been a part of the menopausal treatment and all. And कब से है मतलब andropausal problems तो 20 years से आए हैं. So मतलब I mean they dryness and estrogen creams ये तो पहले है ना
right. So this is just a very small part of the problem. So we all know about only the postmenopausal problem of the vaginal atrophy and the dryness and the less lubrication, etc. So we don't know other problems. They have decreased desire, loss of desire. They have decreased arousal, excitement. They have delayed orgasm. Some females even do not have orgasm, anorgasmia. So all these are not dealt. So which only can be dealt if you actually kind of explore and try to take the proper history in these patients. Yes, good.
What are the neurotransmitters which are involved in female orgasm? You read about, for example, the primary orgasmic failure. What are the pathophysiology of the orgasm? Which neurotransmitter?
You can come here. So the question by Dr. Nachiketa is, what are the various neurotransmitters involved in pathophysiology of female sexual dysfunction?
So mainly oxytocin is involved in orgasmic. If there is deficiency of oxytocin, then the patient may not have. Yes, sir. The patient may not have orgasm if the patient has deficiency of oxytocin. So replacement of oxytocin is the main therapy for female loss of orgasm.
Yeah. So when he is asking about neurotransmitters, you're talking about hormone. So it's not correct. So the neurotransmitters are usually the same as in male. So we have the nitric oxide, we have the PDE, there's enzymes, cyclic GMP, cyclic AMP, all these are involved in kind of a transmission, neurotransmission. Then we have the dopamine agonist with the 5-HT1, because this flibanserin is 5-HT1 antagonist. And then oxytocin, then we have dopamine agonists like apomorphine, etc., which will help in improving the desire and improving the arousal. So almost the same neurotransmitters as in males. But yes. So SSRIs actually can decrease kind of sexual desire. So as in males, because SSRIs are usually required in premature ejaculation. But here we have a delayed or anorgasm. So it's just the opposite. So SSRI would actually inhibit orgasm. So in females, they are usually not required. Right. So this, if we have anybody from the audience who want to say anything, otherwise we'll take up the question answer. So yes. There were a lot of many people. Nikhil was Sate, and there were a lot of many people. But if they want to, please let me know. So the question number one is, which of the following is not an essential part of physical examination in a woman with sexual concerns? Essential part of it. Vital signs, assessment of vaginal pH, palpation of levator and eye, careful inspection of the vulva, and biothesiometry. So I think all these are important, though biothesiometry is kind of a less important in female sexual function. In males, biothesiometry is important to understand the neurogenic cause for erectile dysfunction. But in females, we have a thing called plethysmography, which is often used as a part of the investigation. So I think all these are important. The biothesophysiometry is probably less important in female sexual. Right. So second question, which of the following diagnoses are included in Diagnostic and Statistical Manual of Mental Illness, 5th edition? Female orgasmic disorder, hypoactive sexual desire disorder, genitopelvic pain penetration disorder, A and C above, all of the above. So this is probably A and C because female orgasm, hypoactive sexual desire disorder, I think all the three, A, B, C should be. But let's say. So your answer is A and C. Achha, so arousal disorder and they are included in the same desire disorder in DSM. So that's why they have taken it as one. And the other part is the dyspareunia, vaginismus, and the penetration disorder. Which of the following statements is true? Assessment of patient's intimate relationship is a key aspect of treating sexual problems. Women with spinal cord injury cannot experience orgasm. A linear pattern for sexual response is typical for all women. Survey instruments may take the place of history in evaluation of sexual concepts. All women who have sex with women identify as lesbian or bisexual. Assessment of which one is true? Assessment of so I think A is true. Intimate relationship is a very key aspect of treating sexual problems, particularly in females. What do you think? It is A, right? So A is the answer. The rest of them. Yeah.
Women identify as lesbian or bisexual. So, I mean, if this is wrong, then what do they identify as?
No. So all women who have sex with only women is lesbian. So if they have with men and women, they are called bisexual. So this is the thing is wrong. Na? So all women who have sex with women only, they are not identified as bisexual. They are identified as lesbians, right? I will go back. Assessment of patient's intimate relationship is a key aspect of treating sexual problems. Women with spinal cord injury may experience orgasm, and women may endorse a circular or linear sexual response. Right? So they have both types of response. History is critical to the evaluation of sexual wellness, and up to half of women who have had sex with another woman do not identify as lesbian or bisexual.
It might be part of experimentation.
So they may just out of a kind of a curiosity or something. Yes. So most of them may not be actually lesbian. They are attracted. Yes. Okay. So another thing is about the orgasm. As I said, the orgasm and ejaculation are two different physiologies. So in men, ejaculation is important, and there the spinal cord injury may lead to anejaculation or retrograde ejaculation. Whereas in women, it's mainly orgasm. It's not ejaculation. So in females, orgasm is mainly centrally governed. So spinal injury doesn't cause problem. But have you heard of female ejaculation? So female also can ejaculate, right? There is a gland called Skin's gland, right? Which is almost analog to prostate in males. And this skin glands sometimes get hypertrophic and inflamed. And if in a particular woman, it is hypertrophied or has increased secretion, during orgasm, they will actually ejaculate. So some women, they do expel fluid during orgasm. That is called female ejaculation. Which of the following has not been shown to be useful in management of problems with sexual arousal in women? Topical prostaglandins, muscle relaxants, vaginal lubricants, hormonal supplementation, and psychosocial counseling. So it's muscle relaxants, right? So because when you talk about arousal disorder, which could be due to hormonal issues, decreased lubrication, vaginal dryness, all these problems, and definitely it could be due to psychological issues. So all these are important, and prostaglandins, we all know, help to increase the vascularity and can help to improve the arousal. So muscle relaxants are usually used when there is a pelvic floor dysfunction. So the patients may have some kind of difficulty during penetration. They may have pain, they may have vaginismus sometimes. Vaginismus, you must be knowing, it is the intermittent strong contraction of the outer third of the vagina while attempting coitus, sexual penetration. So the male partner is not able to penetrate vagina because of the contraction of the outer third of the vagina. So that is called vaginismus. And that is very important when we take a history. The patient may come as a infertile couple sometimes because they're not able to penetrate and put ejaculate into the vagina. So which of the following is the possible anterior anatomical location of Grafenberg spot, which is particularly sensitive to tactile stimulation in some women? So anterior wall of the vagina at the level of mid-urethra, cervical canal, clitoral surface, posterior vaginal wall, perianal ring. So, A. As I said, this is anterior wall of the vagina at the level of the mid-urethra. There are many other spots. One is the clitoral spot. One is kind of a anterior fornix, but is also sometimes erogenous in females. That is called A spot. So all these are important spots, erogenous areas, which needs to be explored in females. So that's why female masturbation is so important while while the sex education or counseling is given to patients of female sexual dysfunction. So anterior wall of the vagina, a region in the anterior wall of the vagina in the mid-urethra is particularly sensitive to tactile sensation. Grafenberg's original article identified the erogenous area as arising from the urethra. Controversy still exists over the possible anatomic structure and site of G. Which of the following is most widely studied, most validated physiological test used in the assessment of female sexual function? So laser Doppler imaging, MRI, thermistor, clip, vaginal photoplethysmography, Doppler ultrasound. So it's a photoplethysmography, right? So plethysmography is important to understand the vaginal fullness, vaginal pressure. So these during our arousal and orgasm, usually there is increase in vaginal pressure, the clitoral volume, and all these things. Yeah, laser Doppler imaging. Yeah, so MRI is we all know laser Doppler imaging. With ultrasound, they actually with laser they try to what do they do? What do they see? I am also not very clear about this. Doppler ultrasound, we all know, will help us to know the vascularity of the vagina, the clitoral vessels, the vessels around the vagina, and the labia, etc. So thermistor clip is probably related to increase in temperature. Let's see it just to find out. I think that should be. So there are many physiological monitoring parameters of sexual arousal which could potentially assist in diagnosis. Genital blood flow can be measured with vaginal photoplethysmography, which is the most widely studied physiological test. The method uses a vaginal light source on an acrylic tampon to illuminate the vaginal microcirculation and determine the level of vaginal engorgement. Most studies comparing genital responses of women with and without sexual dysfunction have used vaginal photoplethysmography that measure vaginal pulse amplitude, right? And that is why there is a thing called EROS, which is a vacuum erection device in females, where you just put it over the clitoral area and can produce suction, negative suction, which causes engorgement of the clitoris, increases the vascularity. Choose the correct statement regarding DSM-5 definitions of sexual dysfunction. All disorders, including genitopelvic pain, penetration disorder, require that the symptoms meet the DSM-5 definitions of that condition. Symptoms should be present for 3 months, should occur at least half of the sexual occasions, should cause clinically significant distress. Symptoms can be a consequence of severe relationship distress. So choose the correct statement. What is the answer? D. Symptoms should cause clinical significant distress. So as a part of the definition of DSM-5, they all say that whatever the problem the female have, it should produce some kind of a distress. Otherwise, this is not actually a problem, right? So all disorders except genitopelvic pain penetration disorder require that the symptoms meet the DSM-5 definition of that condition, have been present at least for 6 months on at least 75% of the sexual occasions, cause clinically significant distress, are not a consequence of a non-sexual mental disorder or of a severe relationship distress or other significant stressors, and are not attributable to the effect of a medication or illness. So all these are important when we talk about the DSM definition. We all know there are various drugs which can produce dysfunction also in females. Which of the following is the most prevalent type of female sexual dysfunction? Hypoactive sexual desire disorder, arousal, orgasmic, genitopelvic pain, and vaginismus. So it's a sexual desire disorder. Or arousal. Arousal? Arousal disorder. Arousal. Okay. So this study reported the overall prevalence of female sexual dysfunction associated with low desire to be 37.7%. in study involving 50,000 US women and 31,531 respondents aged 80 to 102 years who were evaluated by validated questionnaires. In this study, 8.9% of women aged 18 to 44 years, 12.3% of women aged 45 to 64 years, and 7.4% of women older than 65 years exhibited low desire accompanied by clinically significant distress. So you mean to say that the desire was more in old age? So the hypoactive sexual desire was low in old age, is it? Okay, that's something strange. Anyway, choose the correct statement regarding FOD, a female orgasmic disorder. Orgasmic disorder almost always occurs as an isolated form of female sexual dysfunction. Selective serotonin reuptake inhibitors are used to treat FOD. The information gathered by the questionnaires about female sexual function is sufficient to arrive at the diagnosis. DSM-5 definition of FOD doesn't contain the criterion that requires orgasmic difficulty to occur despite a normal excitement phase. Systemic testosterone treatment has been approved by FDA for the treatment of FOD. D. So DSM doesn't contain the criteria. So female orgasmic part is not there in DSM-5. The desire arousal is there and the penetration part is there. But the orgasmic part is right. We all know testosterone treatment has been approved by FDA. No, it has not been approved by FDA. And then the information gathered by questionnaires is sufficient. And SSRIs, as I said, would not help in kind of a female orgasmia because they have a delayed or anorgasmia. So choose the correct statement regarding provoked vestibulodynia. Patients with primary PVD appear to have greater nerve fiber density and thicker vulvar vestibule compared to the secondary group. Pelvic floor muscles are usually hypotonic in both. Positive family history and association with enuresis is more commonly encountered, and primary PVD is more common than its secondary counterpart. Local signs of inflammation are a common part of the clinical picture in primary vestibulodynia. Correct. E. A. Patients will appear to have greater nerve fiber density and thicker. A. Okay. So patients with primary PVD appear to have greater nerve fiber density and thicker vulvar vestibule compared to secondary group. An important difference between primary and secondary PVD is the nerve fiber density and the presence of inflammation, respectively. Primary PVD patients appear to have greater nerve fiber density and thicker vulvar vestibule compared to the secondary group. Moreover, hypertonicity of pelvic floor muscles appears to be highly prevalent in patients with PVD. Pelvic muscle dysfunction in patients with PVD can present with decreased muscular strength, reduced speed of contraction coordination, and primary PVD pain experience since the first attempt of any type of vaginal penetration. So this was, I think, all about the MCQs. So if anybody has anything to say, Nikhil, if you want to say anything, I will invite Dr. Nachiket to give his comments.
Hello, sir.
Yeah, Nikhil. So can we
How are
see
you,
your
sir?
face also? Can we see your
Uh,
face?
hello, sir, and
Yes, good.
hello,
So
Dr.
a
Nachiket,
smiling
and all
face.
everybody else present there.
Yeah.
So, I was listening to the topic. I wrote on the chat as well that the things that were probably not covered that well were co-occurrence of pelvic floor disorder along with the LUTS, which is very common in women who come with pelvic floor dysfunction. And there, if uh, uh, is like dysfunctional voiding, and most of them will have a very taut pelvic floor muscle, and you can inject botulinum toxin. If it is injected in the pelvic floor, that treats the dyspareunia as well, along with
Yeah,
improvement
go ahead.
improvement in that. So that was one thing that I thought that can be added there. Another thing, sir, is the controversy. The G spot in itself is a controversial aspect, and the recent research more focuses on the role of clitoris. And clitoris, in fact, is not that only that nubbin-like structure there. It is a multiplanar structure. It is a homologue of penis, so it has its crura, and then the vestibule. The vestibule is a homologue of the bulbar urethra, and as we know that the female urethra is that part which is the prostatic urethra in men, and the lower part of the female urethra sort of penetrates that vestibule, which was supposed to be the bulbar urethra in men. So there is the vaginal vestibules get divided into two halves on either side of the urethra, and they are essentially a part of the clitoral structure. So clitoral structure has the two roots, the clitoral body, and two vaginal vestibules, which are divided because of the urethra penetrating up to the introital area. And that is why, and the vaginal stimulation is only because of the compression of the vaginal vestibules, because vaginal vestibules uh, are also they get erect uh, during the stimulation, and it
Arousal
is
phase.
only the compression of these vaginal vestibules in the anterior part of vagina that causes the stimulation. And there is nothing like G spot. That is another view which is becoming very prominent. And in fact, the upper half of vagina is hardly
Yeah,
sensitive to the touches, and it is hardly erogenous as well. So
right.
these are the other things. And the third thing, that in the question that you mark, hypoactive desire is less common in older women. That is actually that is a misinterpretation. It is associated with less. It is less associated with distress in them. It may be more prevalent. So that is it. The question itself stated that it is hypoactive desire with distress.
Right.
Yeah, so distress might be less, and maybe hypoactive desire must be increasing with age, but they must not be getting distressed because of that at that age.
Very nice, Dr. Nikhil. Very good observations. So thank you very much. The last one was definitely a very good observation because we missed that distress part. That's important. So if we may, the old age women may have a very poor sexual desire, but they may not be distressed with this problem. That's true. Secondly, we did discuss the lower unit tract symptoms part, which is associated with female sexual dysfunction, as in male sexual part. He had a few slides on that, 4 or 5
Oh, maybe
slides.
the initial part.
Yeah, and he discussed about the dyspareunia part also, but the Botox was not discussed, which you had highlighted. Yes, so that may be a treatment part which is there. And Yes, I think that was a very good observation and suggestions. Thank you very much. About the Grafenberg spot, yes, we all know the clitoral orgasm is majority women, they have clitoral orgasm, and some may have vaginal orgasm. They may not respond to clitoral orgasm. So vaginal orgasm, which is either due to the anterior vaginal stimulation or the vestibular stimulation, that may be controversial. So, as per your kind of comments, it is probably more of the vestibule which is responsible for the vaginal orgasm. Right.
Yes.
Thank you. Thank you. So,
Thank you.
Nachiket has something to say. Please go ahead.
Yes.
Good morning, sir. Thank you for keeping this seminar. This is because I learned a lot, and it's one of those things that I guess many urologists. It's a weak subject point for many urologists, and I was surprised when he was giving the data of the precise study that the inclusion criteria was females up till the age of 102. So, on a lighter note, I have a urologist friend in Florida, and he was telling me that he had admitted his parents in old age home. He himself is around 65, and his parents, they are 80, 90. So one day he received a call from the doctor of the old home. You better come fast. And he was feeling the worst. So that's why he left everything, all his patients. And then he reached the old home, and he was ready for everything, that he thought that maybe my mom's not well and she's had some heart attack. So he went over there. So he immediately went to the office of the director of the old home and said, "What happened to mom?" Which if I know, then she's fine. Did she have a heart attack? No, she didn't have a heart attack. Then did she fracture her leg in the bathroom? No. Then why did you call me? Well, I've called you because your mom's spreading syphilis amongst the males of the old age home. So this is the thing that I wanted to add about. And thank you, sir. Who's sir, finishing it off?
So again, very important, very interesting observation. We had a full kind of a session on sexual dysfunction in aging. Males, we said, but in females, it is equally important. So I think there is no age bar or age criteria for sexuality. So old age people, both men and women, are equally sexually active, right? So that kind of a myth has to be kind of removed. Thank you very much. And thank you all those who joined, particularly Dr. Nikhil for his very expert comments, and all our faculty and residents. And I thank the moderator also for making this possible, and our presenter, Dr. Rajeev Sharma, who did a good presentation. Thank you very much.